First of all, I must thank you to organizers, especially Dr. Bansi Sabu and Dr. Amit for inviting me uh, for delivering a lecture, especially in the diabetes and elderly group. Today's my topic is cognitive decline and diabetes. Is it really a vicious cycle? We will discuss in the next 7 to 8 minutes in details. The both diabetic type 1 and diabetic type 2 predispose to cognitive decline leading to the dementia. That is a very important problem, especially in the elderly and diabetes with adult. The stronger association between dementia type 2 and type 1. Type 2 is more responsible for the decline in the cognitive functions. Type 2 diabetes is associated with 50% increase in the risk of dementia. Among the cognitive function, impaired attention, processing, and the motor speed, executive function, and the verbal memory are most commonly affected in the diabetes. The diabetes-related cognitive dysfunction is serious challenge because of the increased prevalence of the diabetes mellitus type 2 in the population. As I said, that it is a real vicious cycle exists between the cognitive decline and the diabetes. The diabetes can increase the risk of the cognitive decline. The cognitive decline itself can then make it harder to manage the diabetes effectively. So there is a vicious cycle. This further worsening and the cognitive function creating the self perpetual loop. The self-management of the diabetes affected by the dementia and mild cognitive impairment. So this is a vicious cycle. In diabetes type 2, there is a lipotoxicity, glycotoxicity, and there is inflammation. It leads to the oxidative stress, then glial activation, acetylcholine impairment, then tauopathy that leads to Alzheimer's disease and mitochondrial dysfunction, then again abnormality in the control of the diabetes mellitus. We'll talk about epidemiology. The estimated prevalence of the dementia is 40 million, and this number is expected to double in every 20 years, to over 110 million in the 2050. The Alzheimer's disease most common cause, which accounts for at least 60% of the cases. The vascular dementia is the second most common cause of this cognitive decline, and it's around 20%. The diabetes in midlife is associated with the 19% greater cognitive decline over the 20 years compared to those without diabetes. This is an important thing. The diabetes mellitus is a significant risk factor for not only for the vascular dementia but for Alzheimer's disease also. A study by Chatterjee they found that the diabetes was significantly associated with the approximately 60% increased risk of the dementia. There was a 40% risk in the non-vascular dementia. For the vascular dementia, there was a stronger effect seen in the women than in the men. There is 18% excess risk in the women with the diabetes is compared with the male. Then risk factors for the mild cognitive impairment. The diabetes type 2 double the risk of the patient developing dementia and AD. The patient taking insulin at the higher risk of the developing dementia. This is an important factor. There's a patients of diabetes taking insulin. They have the higher risk of developing the dementia. And the severity of the diabetes is again the risk factor for the diabetes for the dementia. The individuals without diabetes that have the higher average glucose level also have the increased risk of the dementia. Insulin resistance is again there is a risk of the dementia. Obesity in midlife is again a risk factor, and the metabolic syndrome also increase risk of the cognitive impairment and leads to dementia. The clinical effects. The most commonly effects are the impaired attention, processing and the motor speeds, executive functioning, and the verbal memory. These are the effects on the cognitive impairments. For this, the screening is needed. A mini-mental scale examination and MOCA should be regularly done to screen the cognitive impairment. The deficit in the cognitive functions can be divided into various stages: the diabetic associated cognitive decrements, mild cognitive impairment, and frank dementia. These deficits are severe enough to interfere with the daily activities and are observed across the all age group, not in elderly, but in younger age group also. Uh, some pathophysiology of this cognitive impairment. Uh, the diabetic induced cognitive decline. It may be because of the fluctuation in the glycemic status, the deterioration of the insulin signaling in the brain, microvascular and the microvascular diseases, increased age products, neuroinflammation in the brain, mitochondrial dysfunction, diabetes autonomic dysfunction, and the anti-diabetic drug itself may be responsible for the mild cognitive impairment. A little bit about the insulin signaling and the insulin receptor sensitivity. The circulating insulin across the blood-brain barrier via the saturable transporter. The insulin may be produced by the olfactory bulb and that dentate gyrus and act in the autocrine fashion on the olfactory bulb and the hippocampus. The insulin receptors are the expressed in the neuronal soma and more importantly in the synapse terminals in the have the key role in the preservation of the memory in the hippocampus. The insulin signaling enhance the memory and facilitate the synaptic plasticity in the hippocampus, which has an important role in memory and the learning. Uh, in a normal brain, there is a insulin binding to the receptor at this synapse, triggering phosphorylation in the insulin receptor substrates. This results in the phosphoinositide 3 kinase PI3K activation, AKT phosphorylation, and phosphorylation of GLU-A1, and increased preservation of the GLU-NB2B synapse. And the insulin resistance decreases the level of the insulin receptors and reduces the insulin signaling. This leads to decreased level in GLU-N2B and the GLU-A1 phosphorylation in the synapse and ultimately leading to the impaired synapse plasticity and the memory and decrease this cognitive function. The reduction in the brain insulin signaling increases GSK3B activity, which increases the abnormal tau phosphorylation, and that leads to the later stage is AD. Then there is a role of mitochondria and the cognitive function. The insulin regulates the mitochondrial functions in the presynaptic hippocampus. The amyloid beta can blunt the effect of the insulin on the synaptic terminal mitochondria and deplete the energy reserve required for the synaptic learning and memory. The mitochondrial dysfunctions leads to cortical hypometabolism and a region-specific decline in the glucose utilization and impaired insulin signaling that leads to impaired cognitive function. There is some difference between normal brain and the diabetic brain. The insulin regulates the mitochondrial function in the presynaptic hippocrates. Insulin resistance and the impaired insulin signaling reduces the signaling in the these pathways and decreases the stability of mitochondrial electron transport protein, thereby increasing the oxidative stress. The next important is diabetic autonomic dysfunction. The diabetic or autonomic dysfunction is a common complication of the diabetes. Diabetic autonomic dysfunction is associated with the poor hypertension control and increased risk of the stroke, which are both risk factors for the cognitive impairment, both for vascular and non-vascular. Patients DAN have shown poorer performance on the visual memory, and there is no difference in the verbal and the performance. There are three prevailing hypotheses: neurodegenerative, orthostatic hypotension, and cognitive impairment. And the important is the neuroinflammation, which is more with this diabetes. Then how we can detect? We can MRI can diagnose both structural as well as the functional abnormalities. Reduction in the hippocampus volume is the most common structural abnormality. With improvement in the glycemic control, there is a stabilization of the rate of the brain atrophy. The functional MRI in the patients with diabetes type 2 exhibits worse executive and the memory abilities than the control subjects. The screening. The annual screening is indicated for every adult more than 65 years of age. Screening for the cognitive impairment should also be considered when the individual patients with a significant decline in the clinical status due to the increased problems with the self-care activities and medical management. Then how to prevent the cognition decline? Then the exercise intervention were effective in the reducing the MCI. Aerobic interventions are more useful. Improvement in the verbal memory is also important. Then other potential therapies are the good glycemic control, intranasal route of insulin in type 2, type 1 is now these days is important. Then GLP-1 liraglutide DPP-4 increases the brain GLP-1 levels and they improve this memory decline, and then few studies said that there is an antioxidant and the anti-inflammatory medications is also important to prevent the memory decline. So to conclude, the insulin resistance, metabolic syndrome, and the diabetic mellitus is associated with the decline in the cognitive functions. There is a risk, more risk with diabetes type 2 in comparison to type 1. Patients risk is more with the patients of diabetes with insulin on insulin. MRI and MRS show the great promises to evaluating the structural, functional, and the metabolic changes in the brain and response to the therapy. And the lifestyle intervention and the various drug therapies are used, though there is no so significant evidence is there. Thank you very much.